So my name is Alexander Glaser. I'm a urologist in Chicago at what's called North Shore University Health System, and an affiliate with the University of Chicago. So we know that lower urinary tract symptoms secondary to BPH are both prevalent and costly. But despite this, the precise causes for the development of bothersome LUTS BPH are still unclear, which limits prevention and treatment strategies. We know there are well-established risk factors like age, comorbidities such as sleep apnea, diabetes, metabolic syndrome, cardiovascular disease. And we also know that there's a genetic component to BPH based on both what our patients tell us and then older twin studies. But recently, a polygenic risk score has been developed for BPH based on risk-associated SNPs. And this polygenic risk score correlates with the incidence of BPH, prostate volume, IPSS score, and the need for surgical intervention, such as TURP. And then finally, we know that potentially modifiable risk factors like obesity, level of physical activity, sleep disturbance, and psychosocial factors like depression and anxiety are also linked to LUTS. But what's unknown is if these factors can modulate that inherited genetic risk of LUTS BPH. And so to evaluate this, we leveraged the UK Biobank, which is a large population-based cohort with extensive phenotypic data for about 500,000 patients. And they are aged 40 to 69 at recruitment, median 12 and a half years of follow-up. So what we did is we examined associations of incident BPH with diagnoses of BPH-associated diseases like diabetes, anxiety, depression, sleep apnea, as well as lifestyle variables such as physical activity. And for physical activity, we assessed it with the International Physical Activity Questionnaire, or IPAC, which is a standardized tool used to measure physical activity levels, and one that we frequently use in some of my other projects, such as the NIH Symptoms of Lower Urinary Tract Dysfunction Research Network, or LEARN. And a moderate level of physical activity on the IPAC is equivalent to about a half an hour of at least moderate intensity physical activity on most days. Whereas a high level of activity would be an hour or more of physical activity daily, or a half an hour of very vigorous activity daily. And so what we did is examine the rate of BPH diagnoses compared with different activity levels, as well as controlling for the polygenic risk of BPH. So approximately 15% of the male participants from the UK Biobank were diagnosed with BPH LUTS, and diagnoses of type 2 diabetes, anxiety, depression, sleep apnea were all significantly associated with diagnosis of BPH. Somewhat surprisingly, BMI was similar in men with and without BPH, but both moderate and high levels of physical activity were associated with a lower risk of diagnosis of LUTS BPH. And furthermore, higher activity levels did slightly modulate the inherited risk of BPH. So for men with low genetic risk, the risk of incident BPH with low activity levels is about 14%, which drops a few percentage points with high activity levels. And then for men with high genetic risk, the risk of incident BPH is about 38%. And that again drops a few percentage points with moderate or high physical activity levels. Yeah, so in this large cohort study from the UK Biobank, higher levels of physical activity were associated with a decreased risk of BPH diagnosis, and higher activity levels appear to at least modestly influence the genetic predisposition for BPH. So, clinically, this study provides evidence that at least moderate physical activity, in other words, a half an hour of moderate intensity physical activity a couple times a week, really should be encouraged as part of men's health. And of course, further prospective work is warranted. And I'd like to highlight Scott Bauer's work at UCSF. He is starting the PROUD study, or Prescription Exercise for Older Men with Urinary Disease, which is a single center RCT of a 12-week activity intervention versus control in inactive men with LUTS. And I think this is just a great example of how we can take a concept and preliminary data and really examine causality with an RCT. And so we eagerly await results of that study. Yeah, a major limitation to the UK Biobank or any UK Biobank-based study is that a high percentage of patients, 96%, I believe, are white, which really does limit the ability to study health outcomes and genetic associations in more diverse populations. In addition, participants in the UK Biobank may not be fully representative of the entire UK population. They may be healthier, more affluent, more educated, and that can limit generalizability as well. So more studies in more diverse populations is of course warranted.